And this Friday, we are going to record this meeting. If anybody does not wish to consent to recording, please come on mic and say you don't want to consent, and we will stop the recording. All right. So today we were planning to begin with peer support services and sort of the approach we're looking at for the state plan amendment to add this as a service. Here comes Phil. So we've got him coming in. The thing that I want to share is that I'm aware that there are a series of sort of questions that are percolating about the crisis SPA language and implementation of it. And then if I'm hoping to be able to get to that by the end of the presentation. Also wanted to give a quick update as to where we're at with the Unitas and Point Click Care work going forward under the New Hampshire Care Connections effort the department has, and then to give the last update we have about the supportive housing benefit package. Does anybody have anything else that if we get time, they need to get in a question today or a comment today? Okay. We'll move forward then. I'm going to share screen here, and we'll share this slide deck with folks after. Can you see my screen?
Yes.
Okay, great. Thank you. All right. So I didn't even really have time to put in an agenda into the slide deck. So we're just going to go through a little bit. What we've done, and I think Jeff Atwood hopefully is on from the team that I have in the division. He's pulled up some research for us that I thought would be helpful to go over. Jeff is here. So thank you, Jeff, for pulling this up. But here we have, sort of like some of the information about the case for peer supports. I'm guessing many of the community mental health centers here already have some of this information, but we are working with our actuaries and our finance team in the department. And so it seemed helpful to have some data on how paying for peer support services impacts overall system performance, not just the use of peers, but them not having to be volunteer. They're actually paid for as a Medicaid covered service. So that was the nuance I was trying to make here. So obviously, when we're looking at the Recovery Innovations Program in Arizona, I mean, it's pretty impressive that they saw a 56% reduction in hospital readmission rates. In Washington, we similarly saw about a 32% reduction in reduced involuntary hospitalizations. So there's a couple of other stats here on this slide. Again, I'm going to share that with you folks, so I'm not going to go through all of the content because I want to have more of an open discussion. But there's, quite impressive information. And Jeff, I did pull excerpts of the research report that you found on this and shared it with the actuary this morning. So we flipped them over some specific data. Reduced days of inpatient services have also been a pretty significant reduction across where they have been implemented, like in Tennessee and Wisconsin. Overarchingly, it lowers the overall cost of service where the CMHCs are in a center-specific capitated payment now for managed care. Lowering the overall cost does mean that in theory, we are pushing more into the outpatient services space. And potentially being able to look towards those financial relief in the inpatient space long-term to help impact additional funding in the outpatient space, right? That would be the ideal trajectory that we take a sort of intentional approach about that. Let's see, let me go on to the next slide. Here is some more data. This was specific to a model that was in New York, implemented in New York City, right, Jeff? This was just New York City rather than the whole New York State? Or there is this slide? Okay, this is New York City.
I think so.
Yeah, it was like a 12-month survey of their outpatient. One of the things that obviously, in talking about increase in number of outpatient services, that also butts up against our current workforce challenges that we know the CMHCs are having, right? So when we're looking at implementing an actual peer support service, one of the things that we are looking at is what can we predict for utilization, and that was part of why I asked Jeff to do some research on this. Of course, our actuaries would like some some statistics that they can use to make some predictions. But in reality, we want to have a conversation about what the centers might be planning if we can get this service turned on for January 1st at the very latest, which is what is our target date now.
Excuse me, there's the one disclaimer that I would put forth. A lot of this data is a little none of it was in the last couple of years. I think of the studies I saw, I think 2021 was the most recent, but everything was pretty impressive prior to that. I couldn't find as many more recent studies.
Right. And I'm not surprised. I'm suspecting that because of COVID, they'll wait a couple years to then do like a pre and post COVID analysis, and then get that into publishing. So some of what we'd like to talk about today is at least what I began touching upon. We do need to launch for 1/1/25. That's because that's the latest date. We had, again, hoped to launch for September 1st, but the latest date is because the CCBHC implementation begins 1/1/25, and the adult community reentry program that will be launching with the Department of Corrections, that also has a 1/1/25 implementation. And both of those have a requirement for peer support services for individuals with severe mental illness. So we definitely need these both in place by that date. The additional thing is on the community reentry pre-release services that will be covered. It includes at least one peer. Actually, it includes literally one peer service also. So not only that pre-release screening that we talked about last week, but additionally a peer service. So as of the discussions this week, one of the things to share is that we are tentatively, and I just say tentatively because the department has to make a decision by the end of the month, placing the peer support services for the SMI population, or the CMH population is better, in managed care. This is different than what we normally do. Normally, we would start any new service in the department's fee-for-service space. So even if the individual was covered under managed care, normally the provider would bill the department on a fee-for-service basis. And we would typically do that for a year, so that we can get a good handle on utilization, and work with our actuaries to come up with a good predicted impact on the capitation payments. Because the CCBHC model will largely go through managed care, and the community reentry will as well, I did ask if we could try to put this in managed care so that we have some efficiencies there and a little bit less administrative burden. So what we're looking at in the Division of Medicaid Services is to place it in managed care and to have the managed care organization pay to the CMHCs on a fee-for-service basis. So it would still be in managed care. They could administer it that way, but pay at the fee-for-service rate. For the CCBHC, we haven't finished exploring with the Milliman team whether we would have it paid that way or have it incorporated into the PPS. So that is part of what we were doing some last minute research for, to figure that out. But for right now, at least in managed care, and it would be paid on a fee-for-service basis. So I'll pause. There's Christopher. Thank you. I knew I'd have a question once I got to this part.
Well, I think most of us already are using peers and billing the fee-for-service code. If we suddenly change that and we strip that out, then all of our numbers and our capitated arrangements through directed payments are going to be off if you strip that through and go fee-for-service. Like that's going to be a mess.
So, Chris, when you're saying that you're currently using peer support services and you're currently billing them at the peer support code, is that what you're saying? Or you're
No,
billing
we don't
them
have a
under
peer
functional
support code.
services?
Everything's done on the fee on the
Right. That's what I was double checking that up. Make sure. So you have people that are peer support specialists that are performing functional support services.
right.
Right.
Right,
If we
Okay.
start using this code though, and it's fee for service, I don't know how that works because now I lose that going towards my directed payment calculations, and that's all
No,
fee for service.
that's why we were saying it will be in managed care. So it will be a managed care covered service, but be paid by a fee for service basis.
But so managed care is going to count it both towards our it sounds like you're going to count it both. You're going to give us fee for service payment, and we're going to get credit towards the directed payment numbers. The reason this is important, even though this is directed payment and we don't have maintenance of effort and payback, is it will go into next year's rates. And so if you can assure us you're going to count it in both of those, you're going to pay us and count it. I suppose that's fine, but that doesn't seem right to me.
So you have some services that are covered under managed care in which they pay the center the fee for service rate, right? So H2020 is one of those examples.
Yeah,
right?
But that's not part of the directed payment calculations. Everything that's paid fee for service is carved out, but you're taking something that's part of that and carving it out again after it's already been factored in.
No. Right now, so I just used H2020 as an example. It's a covered service under managed care. So the cost of that is in the department's payment to the managed care organization, the capitated payment that we pay to the managed care organization. And you folks receive you will receive your capitated payment, center specific per member per month payment from the MCOs, and you will still get paid at the fee for service rate by the MCOs. So it's still a covered service as long as the MCO is issuing the payment at the fee for service rate. It's not carved out of managed care. It's just carved out of the per member per month. So it will count for the directed payments. It will absolutely count for the directed payments because the qualifier there is the department has to have the money for the service baked into the payment the department pays the managed care organization. The difference there is on crisis services, that was completely carved out. We did not give managed care organizations money for the mobile crisis services. It's literally from the department to the CMHCs, which is why we couldn't count it for directed payment.
I understand that it's not going to change around how the state pays the MCOs, but it doesn't make sense to me. I agree with Chris that for our case payment that they would peel it out and pay it fee for service and still use it to develop our case rates. That's double dipping. And if the H0038, it appears to be that's lower than the current rate for functional support services, that's a loss for us.
So right now, the cost for a peer support specialist service, not the cost for a functional support service is in there. The actual service is not in your capitated payment, so would not be double dipping. If you are using a peer to provide a functional support service, it's the same as it would be if you had a clinician provide a functional support service. It's just a person who has credentials that can provide that service. We are
That's not
talking about,
entirely accurate how that's been
okay,
structured, Diana, over the years. The state has required that we use the functional support code for peers. When the last time that we updated the rule, the state was not willing to create a separate code at that time. So it's not as black and white as you may think.
Right, and I think maybe that's where the breakdown is that we've all been instructed to use the functional support codes for our peers with an understanding it's not exactly functional support. We make it look that way. And so that's the concern is if now all of those services switch over, we've got a lower rate and we're losing it on the directed payment side. I know we're going to get paid, but the math doesn't work in how the rates get done.
So we're not proposing to remove peer support specialist positions from the qualifying positions that can provide functional support services. So we're not taking it away. You can still use them that way.
Let me ask it this way, Diana.
Yeah.
What's the differentiator then between what we've all been doing, because the billing mechanism you gave us was functional support, and the new code? What's the differentiator between which service we're supposed to do?
So that you can provide an actual service that is called a peer support service. They don't have to be tied to the functional support service role. You can use them that way, but they don't have to. And Evelyn, I don't know if we have any, if you want to jump in here on where we were at with incorporating the role in draft HEM 426 rule changes. But we are literally looking at adding a specific service that you folks will be able to choose to use. You could hire someone to just provide peer support services, or you can keep using them to provide functional support services. See, those are some of the questions I have on the right-hand side. That's why we wanted to talk about this. So we're certainly not suggesting you need to change on functional support services, but as you're building out, if you do intend to build out the specific service of a peer support service, then you can hire people for that and help provide more stability to individuals as well. Kelly, did you want to say something? I'm sorry, I saw your name pop up.
I'm just responding to the chat.
Oh,
I'm
okay.
sorry to say that it does kind of make sense. It makes sense to me. And like you've been asking for it for years.
Mm-hmm.
You got it. And it's not going to take us out of there's potentially some movement from current CAP services that would become maybe peer support, but still there'll be peers who can deliver functional support services, and there will be peer support, and both would count towards a directed payment, if I hear Diana correctly.
Yeah. Ayla, did you want to jump in at all to share some of what you're hearing from the peer support community about us incorporating it into the community mental health centers as a actual Medicaid service?
I think everybody's pretty much said what I was already thinking or going to say. Diana, Kelly, yeah, it's really about aligning with what we've been hearing for several years, and then be looking at where we're going and the feedback we've gotten from community providers. And the draft rules, yes, Diana, are in draft. And from a lot of feedback, we've decided to carve out peer support services, as we've heard, as its own service. And that's why how we've gotten here. Yep. And I think Eve might be having a fire drill in the building. Oh. So that might be why she's not here.
Okay, thank you. Patricia?
Diana, just had a quick question or highlight as it pertains to the PPS 3 rate. Obviously, these codes aren't included in our list of codes currently. For services that would be available to us to bill the PPS3 rate or to have a service day, because they aren't a part of the list. Is the expectation that we would include them since these become effective 1/1?
I believe they were included. They were part of the code set that we provided for the cost reports to get done because it's a required service of the model.
But we didn't
Dr.
have these
Burnett,
codes. We had FSS, but I'll have to look at that code list because obviously they weren't included in the costing because we didn't have these codes. So they didn't exist. We had FSS codes and we know who our peers were, but they weren't a part of the costing. I know Jonathan is on the call, but I don't recall that these were on our list per se. So if we could just check that because that would be essential for us.
Yeah, I think
Sorry, go ahead.
I'll just touch on this quickly. We wouldn't have had a way necessarily to include these in our visit counts for the rate calculation, right? Because we don't have them now. So, yeah, so we just need to get clarity on if they become triggering events for the day rate.
They will. I believe they'll become triggering events for the day rate because our understanding is that we provided these codes. They were supposed to be in the cost report calculations. Dr. Brunette confirmed that her understanding was they were. You know, we jointly meet with Milliman and Myers and Stoppers. So to our knowledge, they were included. So if you find out that they weren't, and maybe maybe we're just completely off, but she's had her finger on the pulse for quite a bit. So Jonathan, follow up with an email sharing this with us because again, it was our understanding they were included.
Yeah. We can look at the list, Diana. It's just, I think Jonathan's point is that in the actual costing, we didn't have these codes, so we weren't able to calculate service provision. So then you can't, and because that's where we are, and then it'll be 2 years before we rebase. It's just a highlight, and it's just to ensure, at least moving forward, that we have an ability to utilize them to trigger a service day. And we'll look at that list, but I just don't remember these codes being on there. So
it is our intention that it would trigger the PPS payment because it's a required service of the model. So that's how we went into it, the discussion with Milliman and with Henry Lippman, et cetera, that it was a required service that is covered by the PPS. So far, I have not received any indication that it would not count for the triggering of the PPS daily rate.
And can I ask one more question, Diana?
Sure. I know Maggie's there, but yes, go ahead.
Is the peer support location restricted?
It's not. The language, at the end of the slide deck, we have several excerpts from other states because we wanted to sort of ask these questions here. I have a little bit of discussion before we come back to the group on the actual language, but it has some provisions in some of these other states of face-to-face, but we need to recognize that could also include telehealth as long as there's like audio visual, right? So I think that's where we're tracking right now. Happy to have more of a discussion about that later.
No, I think that's great.
Yeah, especially because that's baked into the crisis spa, that those could be a person at mobile crisis in person and then someone available on the telephone, also on the encounter. So I think that's the direction we're going. Maggie.
Yeah, Diana, and I've heard Chris say it and I've heard Jay say it, and it's still not penetrating my brain. I was one of the people who testified that I didn't want to use functional supports. I wanted a code for peer support. I thought that the state was going down a funny path and they were making me put a square peg in a round hole, but I obediently did it. Now you're saying, hey, look, you got your dream, Maggie. You have peer support as a code. I'm happy about that. I'm not paid for it when I put it in the square peg as a round hole. I don't understand why the rate changed, and I don't understand how you think I might want to use it when I had something that paid me more and was essentially the same thing because I made it be the same thing like you asked.
Okay. You cut out a little bit, but I think we got most of it. So these are the current rates for the service, the actual peer support service that we have in our system. In the meeting the other day when we were discussing this with the Division of Medicaid Services, Katya, I gave the functional support services rate and then I gave this rate. And she too picked up on the fact that it's a couple dollars cheaper than the functional support services. She was there for all of you folks already saying, they're not going to want to use it. I don't want them having to pay them less, etc. So we haven't gone back to rate setting yet to ask them this. The chat, I don't think it's a matter of us having a problem with the $2. It's a matter of the HB2 rate increases in legislative intent where they wanted us to have parity across systems of care on rates. We do still have exceptions, right? The CMHCs have for a long time had higher rates for some of these services than other providers and other systems had. So we may very well end up right at that same rate. I just can't say that today because of the sensitivity around the legislature's intent for parity. We could take it in a different direction saying, well, it's parity for the other services that they're capable of providing, right? So there's parity across systems, but then what about parity within the system?
But Diana, there isn't parity in the infrastructure, in the administrative infrastructure that you require across systems. If you go into a CMHC rule and all the infrastructure that needs to be in there, that does not compare to what you have to do as a SUD provider or other programs delivering the service.
Right. I think that from the DBH side, there's not really a hesitancy to try to make it the same rate as functional support services. I'm just showing the rate that we currently have for this service in the DBH space. Allie?
Does this require the patient to be state eligible to be reimbursed for this?
We'd be adding it into Medicaid. Oh, sorry, state eligible. You mean CMH eligible?
Yes. So does it need an HW modifier on it?
We would put those on it, yes. The thing that we might not do is we might not add those actual coding lines into MMIS. And you folks should put our guidance would still say to put those modifiers on.
Is it required though that would you pay it with an HE modifier saying that they're not state eligible?
I don't know the answer to that because I want to go back to where we were tracking on the rules.
Okay.
The rules redraft.
And then would it be expected that this would be bundled if there was multiple services in the day, or could it bill out multiple units given throughout the day as separate services?
I don't think we thought about it approaching it like the FSS, so I'm going to write that note down. That's what you mean, like could we bundle it like we can bundle FSF?
Correct.
Diana, the reason I think Allie is asking about the peer code and the not being CMHC eligible is the Medicaid population for the CCBHC sites for the AMI population. Medicaid AMI.
I don't believe we would be putting it in for the AMI population. I am not.
So that's our CMHC non-eligibles in our world, right?
Right. You wouldn't be putting them in as HE, right? If we set up an HE option, you wouldn't take your AMIs and identify them as potentially eligible for CMH?
No, their HE is not eligible.
Right, okay.
And we would bill with that for Medicaid. But my question is, are you requiring an HW modifier on this to be paid?
That would be, that's what my thoughts were based on what we were incorporating into the 426 changes. So of course, 426 is for those who meet CMH eligibility, right? Or if they're in a crisis. So on the crisis side, we'll be okay, that'll be fine. But on the ongoing services, it would be added to the community mental health benefit under the state plan. It wouldn't be added across all populations. Okay, other questions? Now we'll flip back to the last slide. Cheryl, for if it's the mobile crisis services, whether it's the crisis stabilization as a service, mobile crisis services by an ARPA compliant team, or a crisis stabilization center service, yes, it would be billable. So let me look at your note, Patricia.
Would it currently replace the stabilization that they would be able to use at this point?
Sorry, Cheryl, can you say that question again?
So right now for the peer supports, that we can bill like the stabilization for the non-licensed providers, for peer support. So would this replace that stabilization for peer support, or will we continue to use stabilization for them?
You can continue to use stabilization for them.
Okay.
And then Patricia, I'm seeing your note. We have on the peer codes and the PPS 3 rate inclusion says that these codes were pending consideration. I think she just wrote pending consideration because we needed to add them in the state plan. So does your note, Patricia, then mean that you know that you definitely didn't include them?
Well, I know we didn't in our costing.
We didn't because they didn't exist separately.
Yeah. So
Sorry, I didn't
we
mean to
couldn't.
do
So
that.
I think at this point I'm not sure there's much we can do. I just want to put it on there, but I just want to ensure that if we're going to include these moving forward, then we just have to understand that there'll be a trigger code for day of service. And yeah, I mean, that's really all that we need to know. And therefore, we won't be able to, if you will, truly include them until the rebase in 2 years.
Okay.
In costing per se.
So
I mean, we didn't have a way to do this except for FSS,
right.
So we don't know what,
Right. So this is part of why we wanted to talk. It's good that we're surfacing this because this is definitely different than the information that went forward in the discussion. So we know that in order for Medicaid to pay for it, it will for it to be a covered service that the individuals will need a certification. And I saw a little bit of discussion about that in the chat. Cheryl, you had asked about, will they require the peer to obtain the CRSW? And Ayla has said that they would need the CPSS. But I think in the rule, and I don't know if Evelyn's back with me, in the rule changes that we were looking at, yeah, she's back. We were looking at peers being able to be certified in both directions, so they could be, for it to be a covered service under the CMH population. So if they were trained as a CRSW or they were trained as a CPSS, that both would count. But that might not, I might be a little out of the loop on there since we launched this other big project. Ayla and Evelyn, will you talk about this a little bit, where we're at within the rule?
The rule piece, I know we drafted some early language, but we haven't had a chance to go in to refine that based on, I think, the current conversations. The conversations we've had around the peer supports has looked at the use of CRSWs with regards to SUD related needs and the peer support specialist for the mental health related needs. And we've been looking at individuals could have dual certifications to be able to work with both populations, but that for mental health purposes, we're looking at the peer support specialists specific to that role. With the CMHC piece and having serving both populations for mental health and substance use disorder, there is, I think, a greater talk about both of those within that. But I think for 426, for the rule updates, we were looking at that specifically being the peer support specialist, not the CRSW role. Ayla, I don't know if you have anything to add on that or other perspective.
Yeah, that's my understanding. Yep. It's really important to have them be distinct in the way that we define them and the way that we recognize them in our rules for the equity of both professions and, knowledge base and who they're serving and supporting.
So we would be able to, we'd have them in the rule and be intentional about that we want this kind of certification to be providing the peers for the mental health needs and this other kind of certification for the SUD needs, right? Is that what I heard? Is that captured here right on the screen? Okay. Jen?
Sorry, I had to find the mic. So I had a question. Will it still apply as it has in the rule currently that, folks don't come to us with that certification per se, so that they'll still have a year before to be able to take the course, get the certification, and still be able to use the code or not?
I believe that's the intention, the way that things are drafted at this time. Yep. To not change that piece.
We would have, the department has to, we still have to have some sort of certification for it to be a Medicaid covered service. So I think the nuance there is that by a person being able to comply with what we put in the rule, the department would certify that, that makes them certified as long as they cover the qualifications under the rule. So if the rule says they have to have XYZ background and experience and achieve the specific certification within a year, then the person would meet the rule that way. They could be certified by the department in that respect. So, right, Ayla, that's what we talked about?
Yep, that's correct. Yeah.
So we would use the rule to give the department the authority to certify the person for the provision of the actual service, which is allowed.
Yeah, and I've highlighted the need to maintain that 1 year grace period, if you will, because of some of the workforce challenges and so forth that we're all aware of.
And Ayla, there's a grandfathered, right? This isn't effective moving forward. And then there's grandfathering for people who already have a certification that may not in fact be CPSS.
So let me,
well, the CPSS that's recognized, by the state has always been that for at least the past, I think, several years, 6 or 7. And the short answer is yes. If you have your CPSS, you have your CPSS. That's the intention in the direction that we're going, as far as I'm aware. It's really about, as long as we just have to be mindful the way we write things in the rules so that we're not excluding anybody in some unintended way.
So we have to make sure the rule addresses the grandfathering, just not called grandfathering, right?
Right.
And then
yeah,
yes,
like recognition of anyone previously certified under the department again, that language, the department approved process X, Y, and Z.
Okay. Kelly, I'm sorry. I know you've been very patient. Oh, you're muted still.
I'm not sure that my question is still relevant because it starts at the beginning of what you said, and some of your clarification about the certification types might change it. But I just, because I take the notes and my notes go back to my management team. I just want to make sure, initially, what I heard you say was that it would, you were talking about the certifications working in both directions, but I want to make sure that I'm documenting it right when I say in either direction. So that you wouldn't be saying they had to be both a CRSW and a CPSS. You would be saying, setting aside wherever you land based on the conversation and the rest of the information that you cull, if you accepted CRSS and CPSS, they'd have to be one or the other.
Not necessarily, because we already know that we have duly certified individuals within the CMHC system working. I know that doesn't mean they're billing in two different directions, but not currently at least. But I think what we're saying, Diana, correct me if I'm wrong, somebody could be duly certified and then therefore be providing an array or different services based on whoever they're working with. And then I assume that would dictate how you're billing under SED or mental health. So that person might be duly certified, but then yes, you'll have your individuals that may be certified on kind of one side or the other. And then that would dictate where you're, does that answer your question?
Yes,
okay.
Yes.
And I just put that note in there so that when you guys get the slide deck, you'll have that there too for notes. Okay. So right now on the SUD side, there's no max daily unit. I don't think that we are contemplating a daily unit for the SMI, the CMH eligible population, both for reasons of parity, plus the fact that is, widely recognized as a service that leads to better outcomes and lower costs of care anyways, right? But I didn't know if the centers had any concerns or feedback about this. I mean, really, if it's medically necessary, right, that's what you would want in the treatment plan to articulate. And then we should be all set from our perspective. Okay. So are all CMHCs currently using peers to provide functional support services? This was a question that we were trying to land on. 100%. And we heard a couple of different thoughts from people in the DBH space. So we're just trying to confirm if every center is currently using peers for functional support services.
We're required to do that. We're required to have, excuse me, peers on the ACT team. And the only way you can bill is with a functional support code currently.
It's currently the only avenue that we've been given.
Yes. I'm glad you just said that, Jay, but I still would need to confirm if that's what we're doing. If it's only for ACT, if everyone is doing it only for ACT, then I will make that note. But is anybody not using peers for people that are not on ACT?
I think you should
use peers to provide functional support.
I'm sorry, Maggie?
I think you can with 100% certainty say that every community mental health center bills peer support under functional support for all teams. It doesn't matter. Wherever there's a peer support person, they're billing functional supports. That's 100% positive.
So they're all using peers for functional support. That's fine. Does every center have peers on staff?
I think you have to think of the language differently. We're using peers and you're requiring us to bill functional support.
Okay. All right.
So
So I want to jump into this because from what I've heard, it's not exactly accurate of what I'm hearing now. So I want to clarify, maybe Diana is not, maybe it is the language she's using. So I want to make sure she's getting the answer, what she's looking for. So we understand that that's what we've told you as a department. If you're going to use peers, you need to bill under this. I know that. And that's like your only option. I also know that. What we're wondering though is we have actually heard, and I'm not going to call people out, but we've heard from you guys in the provider network that there's actually agencies that don't bill that way. They choose, or they have chosen in the past to not bill under FSS because of philosophical and other reasons, I guess. So what she's trying to really confirm is, are you all like, is everyone saying, yes, we are now? Maybe you weren't in the past, but yes, we are now. I do hear the majority, but some agencies I didn't see say yes. So that's what we're really trying to confirm.
Kelly? You're on mute.
So if anybody isn't, I just want to understand the question again, because Ayla, you did clarify it, but now it isn't clear. Is the question whether we're using peers to deliver FSS across the agency, or is the question whether we're billing for FSS for peers delivering services across the agency?
That's a great clarification, because I think there is two questions. I mean, as far as I'm aware, because of what I do with the peer workforce, I know that there's at minimum, if not more, of one peer in every CMHC. I know that for a fact. The other side of what the second question is, what I don't know, is whether or not every agency is necessarily billing that peer under FSS.
Patricia, are you responding to those questions, or do you have a new question?
Nope, responding to the question.
Okay, go ahead.
So at Manchester, I think it's both. We have peers billing FSS for when it meets the criteria for FSS, and then sometimes they don't bill because it doesn't meet, because it's truly peer support. So it's both. In
Ditto.
Manchester.
And I heard that for at least 2 centers. Any others have that same experience?
Yes, Riverbend, we have peers that are connected to obviously ACT, but also for our psychiatric emergency services team, they're doing FSS crisis actually as part of crisis stabilization, but only if it makes sense, only if they're actually doing functional support for crisis, and they wouldn't bill otherwise.
Thank you. Is that the same for everybody, or are you only using a PSS to deliver a fee for service, a functional support service? Bill?
For MFS, it's most to my knowledge, mostly functional support services if it meets that criteria.
Okay.
It's the same for Northern, Diana.
Thank you.
Same for Seacoast.
Can you repeat the question? Sorry.
Are you using PSS, so peers, only for billable functional support services?
So we use peers to provide peer support, and we bill it through functional support services. We also have support specialists who are our primary functional support service providers. I don't know if that answers the question.
Yeah, it does. It's interesting. So what I think I'm hearing is yes, you do use peers for billable functional support services that essentially meet the criteria of a functional support, but you also use peers for functional support services that or other like true peer services.
We
Even if
only,
they don't.
no. We only, our peers are providing peer support services. And I think as Maggie said, we're doing the square peg round hole and figuring out which billing code they can use for that. So they don't use all the functional support services billing codes. There are certain ones. I don't know what they are off the top of my head, Surly. And then we have functional support staff who literally are intended to be providing functional support services. So our peers are not tasked with providing functional support. Our peers are tasked with providing peer support. And we used whatever guidance the state provided way back when. It was like bill functional support, bill this way. We used that guidance to create our process for billing, for what documentation they used. Does that make sense?
Yeah. Yes, it does.
Okay, thanks.
West Central is using peers to provide functional support services and billing as such.
Okay.
And to be clear, we're using it for OCT, but also rapid response. I assume everybody's doing the same thing, but.
Right.
We have them on other teams as well, not just app. So. And rapid response. We have them spread across other teams. Mainly because of CCBHC requirements.
Does anybody use peers for serving the children's population?
We don't.
I'm seeing a lot of shaking heads now.
Only not outside of mobile crisis.
Right,
yeah,
not outside of mobile crisis.
In mobile crisis.
That is the exception.
Rapid response.
Yeah.
Right. On the outpatient end, we refer to NAMI for those.
And as part of this, is there a desire to have a peer service for children? Because we would write that differently.
I see using it for family support, potentially in a children's case.
Right, because that's a functional support.
Yeah.
Right.
But we also have specific functional support employees who we would probably task with doing functional supports with the kids specifically. And I can see using peers with families. See what I'm saying?
Do all of you believe that we should have a children's version of the peer support specialist service?
I'm thinking that's part of CCBHC. If there's family is, we have to provide peer services to families. I'm not sure exactly if the youth are included in that.
Yeah, I know that there was family support, and we had codes in there for family support for the CCBHC. And we thought that could meet the definition of, it could be compliant with the CCBHC model. Yeah. Does anybody not want us to pursue a children's one?
Seems like it would
if we'll be able to. Go ahead. I'm sorry, Phil.
It seems like it would require some more study, right? Because what's the peer? Is it parent to parent? Is it teenager to teenager? Is it middle school to middle school kid? I mean, when you say that, right? Who's the peer?
Mm-hmm. Yeah, and we might not be ready for it.
We can't hire people below a certain age, So that's why it says specific to working with the family, because it's not going to be a peer to have a 50-year-old peer working with a 10-year-old.
Right, exactly. So Ayla, what were you going to say?
Yeah, so right now the implications in the way our rules are written specifically around the mental health peer specialist, I'm not talking about any other realm, is speaking to adult peer support, so ages 18 and older. And in precedents of nationally, peer support and family peer support are all distinct. Mental health, substance use, family, youth, those are all distinct peer support tracks, if you will.
Just gonna say family style. Kelly?
It just gives me a little anxiety all the time when we get this far down into all these questions around the administrative rule. So is there a timeline for rule development? Because in those areas that we're continuing to emerge services without a rule and we're dealing like either through contract language or guidance documents, we're not always current in the issuance of what practices versus what document we have on file, and it's difficult to do without a rule. So just wondering when the rule will follow.
Evelyn, do you happen to have a current timeline?
We don't have an update on the timeline. I know we've tried to share it in a few meetings, but not everybody's at the same meetings. So I recognize that we don't always have this up and shared in real time. We have the draft changes that were made with our CMHC representatives back when Philip was with us. We were working through those with administration. We identified with a number of these Medicaid initiatives, though, that we needed to further explore what the initiative would look like before we could craft the language to reflect that accurately for the rule revisions. So for 426 specifically, we have the draft updates that were done collaboratively that we're reviewing the questions on. We're working through like these Friday conversations to fully identify the implications. And then we're going to go back into those rules, make sure that everything aligns from these conversations with what was drafted, and we'll bring those forward. Because our rulemaking takes 6 months once we file it to get it through the process of going through the MCAC, the public hearings, the rulemaking process, we really try not to open them repeatedly and try to get everything reflected as best as we can before we file it. So it's hopefully we'll be able to get that one moving by the end of this calendar year, so we can get that kicked off, knowing that it takes 6 months, but we don't have an exact timeline as to when that will be wrapped up to file. And your hand is back up, Kelly.
Yes, so I just want to say, especially because I know I'm being recorded, that how that translates to my ears is, well, we're not really done our rule because we still have a lot of questions and everything isn't clear. And when it is, we'll have a rule. But in the meantime, you'll be asking us to stand up a benefit that apparently isn't completely clear to all of you. And I don't know how it's supposed to be clear to us. And then that gives me real anxiety around being compliant with what the expectation is.
Absolutely understood. And one of the discussions we've had internally is that while we're still exploring the rulemaking pieces, we're going to work between Diana's staff and our attorney on any guidance to be issued. So example being, a few years back, we had, or maybe a year or so ago, we issued guidance about the ISP reviews. So we implemented out to all of our centers. Here's our guidance on how ISP reviews are to be implemented. Here's how it might deviate or further expand off of what's in the rule. Here's the expectation to follow up until the rule is updated. So we have talked with our attorney and with Diana's staff about reflecting some similar kind of guidance if needed for anything that would be not aligned with the rule, so that while we're still going through that rulemaking, we can provide that guidance out to the centers. And the areas that we've been really looking at, I think, have focused on the changes around the mobile crisis response work because we were working on those pieces. So that was one of the big areas we needed to kind of fully understand before we could fully craft that language in the rule. And then the peer conversation today was another big area that we've had a lot of conversations about making sure that we accurately reflect it. So.
Yeah, and I know we're past time right now. I did want to share that on the SUD, in the SUD system, we had made numerous changes for the opioid treatment programs, and council advised us to use this very specific approach that we hadn't used in the past, at least not to my knowledge, which was essentially the language in the rule was so specific that we did not feel like we had space to address it just through guidance. And so the parts that we could address through guidance, we did. The parts that we couldn't, we essentially developed a standard template for a location-based waiver so that and we put these in the guidance, we released them, we drafted the waivers, and we invited the OTPs to submit those waivers. And basically what that did allow us to do is across the population that you served, that you would be able to do it under the waiver, the blanket waiver. You would not have to submit a waiver by client, right? And that was the most legally sound approach until we would readopt the rules, because in that case we were changing based on a change at federal levels that we would need to memorialize at state levels. I think that's what we're going to need to do for the prior authorization lifting of the having to get a waiver to exceed the exceed the 10 units. So I just wanted to get back to you on that because we have successfully done that in this past year in another system. And that's why I don't have it for you yet, because I'm going to have our lawyers review it so I can give it back. But we are still there. We're still past crisis spa. I understand that there's some questions that I don't know if it's happening in the QI groups or the crisis groups, but what I would ask is if the centers could put together what their questions are and submit them both to me and to BMHS, that would be great. It's kind of hard to address them when they're coming up in like lots of different questions. So if you folks have some specific ones that you want to get together and submit, that's fine, or we can hold a special Friday session to do that. We, on the Unite Us and Point Click Care work, we are beginning to knock on the doors now with the centers for those crisis scenarios, the mobile crisis scenarios, and for New Hampshire hospitals backdoor. So there's the workflows and the partners involved for the care traffic control, but we're moving into the discussions of the discharge. So we are having the program areas specify who their partners are. The CMHCs were identified as partners for the discharge planning for New Hampshire Hospital. And that includes not just your clinical, but your housing services. So if folks are, have any concerns about that, please do let me know. I'm the project manager for that whole initiative. So that's helpful to hear that feedback. Supporting housing, we have a question to CMS about conflict-free case management that we're trying to get clarified. Hopefully we will have that answer shortly. Thank you, everybody. Sorry to hold you late. I appreciate all of your time and the work you do and the great discussion. Thank you so much.
Thanks,
Have a great weekend. Thanks.
You too.